not a treatment for suicide or for suicide ideation. And I don't think anybody is espousing that it is. But I do contest, I think, the message that has been somehow portrayed that women who are in a crisis situation of mental health or a crisis pregnancy somehow will be able to dupe professionals into giving them an abortion. And I take great offence for women and for professionals that they somehow would be duped by women who are in crisis. And I think that needs to be at the fore of our minds as we contemplate and reflect on what's going on here today. The second issue I'd like to raise, it's something that Professor O'Keane mentioned, and I think it's very, very worthwhile and very timely, that often these women will not end up in maternity hospitals, will not end up in departments of psychiatry, but will arrive in their local GP or a GP surgery up the road, maybe for fear of the negative stigma that they would have for having, first and foremost, the feeling of suicide ideation, and second of all, to inquire about their access and information to abortion services. So where do ye as professionals see that what we need to do as legislators to inform and to instruct GPs who are at the coalface and who unfortunately aren't represented in the hearings over the next couple of days, because they are the people who these women in crisis will be faced with to make the hard decisions and to get the information. And the information that they receive at that point will be instrumental in their own outcome. And I think that's really, really important. The third and final thing that I would like to say is in relation to numbers that have been spoken about 1 in 500,000 women may die from suicide in pregnancy. And I would just say and reiterate the sentiments that have been stated here by other colleagues, that is not because the numbers are so few, to my mind, that's not a reason not to legislate, because one is one too many, and that's the reality of it. Because what if that one person is your mother or your sister or your auntie or your daughter? And finally, what I would like to say in relation to this whole area is about there has been some discussion about getting second opinions when somebody presents, and I know that Dr. McCarthy had said at the very beginning of his presentation that there is division within the college on this issue. And so how many psychiatrists would we need to make a decision like this? Because we heard from the masters of the hospital, of the maternity hospitals this morning, where they said if somebody had an underlying cardiology issue, that they would consult a cardiologist. If it's a mental health issue, they would consult a psychiatrist. And so given the division that's within your college, I would just like to know what you would determine to be I suppose the most effective number in relation to making that decision.
Thank you very much. Dr. McCarthy, do you want to start up?
Okay. Do I sit or stand for these?
Stand, I think, would be most if you're comfortable.
Okay.
So people can hear at the back of the chamber as well.
Okay, so I can go through all the various answers.
Yeah, and we have 6 other speakers who've indicated in this session as well. So
I'll try and be quick.
Thank you.
Will women with high-risk pregnancies, are women with high-risk pregnancies going abroad? Without seeing this 130,000 and actually assessing them, can we say that definitively? Of course not. However, what's our impression? Number one, we see women in pregnancy who report to us regularly that had previous terminations, and the reasons for that very often would have been they were very depressed or suicidal. They didn't want that pregnancy before, they were worried about their mental health. We certainly know statistics in countries where abortion is illegal and not available to mothers. The rates of suicide and infanticide are much higher than they would be in countries where abortion is available. We know in Ireland, for example, from 1900 to 1950, 10% of mothers of childbearing age, 10% of women of childbearing age who committed suicide were pregnant at the time they committed suicide. Nowadays, it's 2%. So that would suggest that whether that's contraception, whether it's abortion, we don't know, but certainly the rates have gone down in that time. And certainly if we were to go before that, I mean, the appalling statistics on infanticide and, studies, say Elaine Farrell studies in Queen's University of 4,960 infanticides between 1850 and 1900. Cleena Rattigan's painful book last year on infanticide and pregnancy in Ireland, epidemics of it between 1900 and 1950, plus suicides, would very much suggest there was a huge, big problem, and that has been reduced possibly by socioeconomic factors. Women are not so poor, possibly by contraception, but I've no doubt many women are going to England for terminations of pregnancy. So that's the direct answer to your question. Do we have the ability to differentiate? I tried to say that we have huge skills. We're trained all the time to do risk assessments. As I said, do we always get it right? No. Do we get it wrong sometimes? Of course. Are we trained at doing risk assessment? Yes. Do we come up with treatment plans all the time, most of the time, which is effective? Yes. But of course, we will sometimes get it wrong. We all do the same training, but at the end of the day, like the decisions that the clinicians in Holles Street will make about when do I induce a labour or not, when do I do a caesarean section or not. You know, medicine is throughout has subjective decision making on the basis of some objective facts. We have a lot of objective training. At the end of the day, there will be differences always because of subjective elements, and that's human nature, that's life, and we have to deal with that. The questions about if it's so rare, can we not legislate? I think that's really an issue for the legislature. You know, we do know these do happen, they are rare. The legislature is dealing with it. If it doesn't deal with it, I know my obstetric colleagues feel very exposed. The 1861 Act is still there, and if the legislature has to make up its mind about that, we're clinicians, not legislators, but obviously we can sometimes be in difficult clinical situations. Yes, we're short of perinatal psychiatrists, definitely. Do we need more? Yes. Does it have to be? And maybe there's a combination of answers on this, and the question of the general practitioners as well. Women mostly, as Professor Keane said, will not be coming to psychiatrists first. Women who are pregnant will present to their GP, maybe go to Positive Options Group, maybe go to a Well Woman clinic. They'll be assessed. If they're depressed and distressed, they may be suicidal, but there's no question of them even thinking about an abortion. They may be referred to a local psychiatrist. They may be treated in that way. It's actually going to be a very, very small group, in my view, who are going to be depressed, distressed, and who want an abortion, and who want to access a process here. Because if they feel they have to go through a process of 2 psychiatrists and an obstetrician and possibly appeal and possibly legal things, they're not going to come near us. And I don't think that's particularly going to change. So I'm not seeing this epidemic coming our way because this actually legislation is so narrow. Really, it is so narrow in looking just at the life of the mother in this way. Will it lead to floodgates? Again, because it's so narrow in my view, I can't see the floodgates opening. I'm not a predictor of social trends and how with society changing other things may happen, but at the moment I certainly can't see that because it's so small. And the final question, duping, I mean, as I think I said in my submission, I mean, the appalling abuse of women in all of this, that they're all manipulators, is just dreadful. And the fact that that was all it was. The fact that we, in addition, are sort of supposed to be naive and easily duped is another matter. I don't take so much offence at that. I think actually it's the women we see who should be taking the offence, not us. We can deal with it. I'll leave my answer at that.
Dr. Casey.
Thank you. A lot of questions to go through. The answer, firstly, Mr. Kelleher's question, do we know how many women are going to Britain for abortions who might be suicidal? And the answer is we don't. There is no information because the British statistics don't collect the reason for women having abortions except in very broad terms like mental health, physical health, that kind of thing. So there's no information and it's speculative. And I have certainly had women coming to me who have been to Britain for abortions as well. And they would say, yes, they didn't want to be pregnant. But when you say, you know, were you given any treatment, any help, any advice, they say no. And that's the crucial thing. We don't know if these women are going to Britain because they're just not being given any alternatives to abortion. If they are depressed, have they seen GPs or people who can treat them? That's the problem. We're speaking in limbo here. We don't actually have any concrete facts on which to base decisions. Is there the potential for self-harm among some of them and suicide? We don't know because we just don't have the statistics. Are we clinically able to differentiate between suicidal ideation, suicide intent, passive death wishes, active death wishes? The answer is yes. Where we have the difficulty is in an individual case identifying who of the people we're seeing is actually going to go on to take their lives. We can know how they are in the here and now, but if you ask me down the road in 2 months or in 6 months or in 10 months, will this lady have died by suicide because she is now depressed? I cannot answer that question. All of the studies that have been carried out suggest we cannot answer that question. And the studies have been conducted on psychiatrists treating people, not people who are not going to psychiatrists, but they're people attending psychiatrists. And when psychiatrists have been asked to try and predict down the road who is going to die by suicide, we cannot do that. Now, turning to, yes, if Mr. O'Callaghan's question, if it's rare, is this a reason not to legislate? Well, legislation has always got to be based on good medicine, and it's got to be based on fact. And there are a lot of assumptions in these questions that if a woman is suicidal in pregnancy, an abortion is the only thing that will help. Abortion is and there is no other alternative, and she needs an abortion, and abortion is the only thing that will help. That's a chain that doesn't necessarily flow. That's a linear chain, that a woman who is suicidal needs an abortion and that the abortion is going to be helpful. Because an abortion may harm people, and there is no way of knowing, and the balance of evidence is that abortion either has a neutral effect or on some has a negative effect. So there are too many unknowns there to suggest that this kind of legislation, it would be based on anything scientific or evidence-based. Comment on perinatal psychiatry. Yes, we are definitely short of perinatal psychiatrists. There's no doubt about that. But I have to say, psychiatrists around the country see suicidal people every day. And they do suicide risk assessments, you know, up and down the country, from Kerry to Donegal, from Drogheda over to Galway. And these can be done on anybody who is suicidal. But yes, we do need more perinatal psychiatrists for difficult cases. Mr. O'Callaghan mentioned the possibility of abuse, which I have mentioned in my report on. Now, the reason I've raised the question, will the suicide ground for abortion be open to abuse, is because it's a valid question. Lots of people are asking it. And I'm not answering it here, but I'm giving you some information that may assist. And a comment from the British Pregnancy Advisory Service, published in their May edition last year. And the British Pregnancy Advisory Service are the biggest providers of abortion services in the UK. And they say, it is not the case that the majority of women seeking abortions underground C are necessarily at risk of damaging their health if they continue the pregnancy. But it is significant that because of the law, women and their doctors have to indicate that this is the case. So I think these are valid issues to raise when discussing such a serious matter. Will legislation open the floodgates? I think that they may not open the floodgates immediately, but there will certainly be widespread abortion within a short period of time. Because I think what will happen, even though Dr. McCarthy doesn't believe that people will come near psychiatrists in Ireland, what will happen is GPs, in good faith, will send women who are pregnant to the doctors to be assessed to see if they come within the X criteria. And the system will be described as cumbersome, and in due course it will be dismantled, and I think there will be a gradual opening up, as has happened in every other country. We are no different from any other country in the world. Women may manipulate. I don't believe that women will manipulate. I believe that in every situation we have to take a complete history and reach our diagnosis based on the totality of the information. And I think, yes, somebody mentioned, Ms. Conway, that women won't go to maternity hospitals, as did Dr. O'Kane, but it's surprising that women who are currently suicidal don't even come to the psychiatric outpatient clinics or to the self-harm services such as the ones that I'm running. GPs send people to those services all the time, people who have suicidal thoughts and suicidal plans, and they send them up for assessment, and we are just not seeing them. I recently saw 2 women who had overdosed, as I said, in that service, and both of them wanted abortions, but that was because they were being coerced. We are not seeing many of these at all. Thank you.
Thank you. Dr. O'Kane.
Thanks. I'm not going to repeat what my colleagues have said, but I think there are 2 points that I'd like to make in relation to the questions that have been asked. And one is in relation to Deputy Kelleher's question about the 130,000 women who've gone to the UK. and what percentage of them may have been suicidal. And that can be really answered by inference, although not directly, from looking at the reasons why women have abortions in other jurisdictions where it is legal and available. And most women have abortions for mental health reasons. So it would be my view, and I think one could say in all probability that certainly a percentage of those women who do go to the UK do so because they are very mentally distressed and suicidal. And I think the issue in relation to suicide is important because suicide doesn't always occur, and I have to disagree with my colleague Professor Casey in this regard, doesn't always occur in the context of mental illness. People can have an episode of depression. They could be at the beginning of an episode of depression. That's a mental disorder. It's not really what would constitute a mental illness. So, or they may take their life in the context of stressors that are unbearable to them, such as unemployment with men, and that's something that's more familiar to us, possibly. The other point I'd like to say is that in relation to the floodgates opening and so on and so forth, and what this legislation might mean and might bring further down the line, I don't think we should be, and it's not my job, but my advice, I suppose, as a professional is that this debate is springing out of a need. It's springing out of reality, out of cases that we've all lived with nationally, you know, and been traumatized by. And you know, we're here advising you legislators about it, and I don't think we should be prevented from legislation because the legislation may be abused. I think what we need to do is to put mechanisms so that it won't be abused, like we have with the mental health legislation, where we have an inspector of mental health services, and the inspector inspects just that. They look at it from the patient perspective and from the point of view of the that are given to the patient who come in. Are psychiatric units adequate, and so on and so forth? Are the ways that the patients are being treated adequate, and so on? So I think any legislation that does come in could be managed in this sort of way. And then just in relation to Deputy Ciara Conway's point about 2 psychiatrists being necessary. Can nobody hear me? But Patricia's is on, mine isn't. So maybe I should lean in here.
No, it's working. It's actually working. It's actually working. No,
I'll stay here. So do I have to say it all again, or I'll just go on?
I think your knee is playing havoc with the switch. It's okay. You're fine.
Oh, okay. Sorry about that. Okay, but just in relation to Deputy Ciara Conway's point about we seem to have differing views here. I mean, I think that as professionals, we will all work within the law. Whatever the law is, we will work within it. And if we don't, the professional organisations are there to pull us in on that one, and they do operate. And, you know, there is a system of reporting colleagues and so on and so forth. I don't really see why 2 psychiatrists, my own view would be, I don't really see why 2 psychiatrists are necessary for this particular legislation if there is a redress board for the patients, and I think that is one of the recommendations of the expert group.
Thank you. Okay. Senator Colin Burke, Senator Mark McSharry, Deputy Dennis Naughton in this segment. We have 7 people indicating to speak.
Thank you,
So
Chairperson.
be brief, please.
Could I thank the guests who have come in here today. Just in relation to the expert report, it gives a number of different options as regards whether it should be 2 specialists, whether it should be 2 specialists plus an obstetrician, or whether it should be a specialist and an obstetrician. I'm just wondering what the panel feels as regards the most workable solution there in those proposals. That's question number 1. Question number 2 is in relation to someone who is suicidal. And one of the consultants referred to it earlier this morning about, you know, if a person, say if it's a male, is admitted to hospital with suicidal tendencies, there's a course of treatment. Likewise, I presume someone who's pregnant would be prescribed a course of treatment. And say someone who's, say, 18 weeks pregnant, do they feel that that patient can be managed successfully to a safe period when the baby can be delivered that will then survive? And the third issue that I want to raise, and just quoting from a UK report, the CMAC report, and it made 10 recommendations at the start of the report. It said, and I'm just quoting one, women whose pregnancies become complicated by potentially serious medical or mental health conditions should have an immediate referral to the appropriate specialist centres of expertise as soon as their symptoms develop. And the report goes on and says, the assessors have been struck by the lack of appropriate referral of potentially high-risk women, and lack of consultant involvement remains a problem in the care of women with serious medical problems. I was just wondering, do the panel, and there was a referral there to GPs, a lot of people going to GPs, do the panel feel that there's enough being done in relation to medical services about referring people to the specialists at an earlier stage than what's happening? And I'm just maybe they might make some comments on that issue.
Thank you. Senator McSharry.
Thanks very much, Cathaoirleach, and thanks for the presentations. Can I ask, just in light of what has been said in the context of only 3 perinatal psychiatrists being available in Ireland, if I, or my, obviously not me, but my sister or niece or wife or neighbour presented to the GP, said that they were suicidal and wished to see one of yourselves to discuss that what's been averted, how long would it take from somebody outside the main centres to get to see you? And if they did, notwithstanding the fact that every situation is of course different and it is a complex issue, how long typically, to the extent that you can comment, might it take to give a diagnosis that in fact somebody was suicidal, and that in fact, let's say, post-legislation, that an abortion, as Professor O'Keefe has said, may be, in the very, very rarest of instances, a part of a treatment, or of help as part of a treatment. And can you answer that in the context of where I'm conscious that you've said that as a profession, for every 100 suicides that you may predict, only 3 materialised. Does that then mean that for those women, however rare that it was, where you would feel that a termination may be part of that treatment, for every 100 of them, are the statistics, or would they be similar? So is it conceivable, therefore, that we may determine that 100 terminations were necessary for saving 3 lives?
Senator McSharry. Deputy Naughton.
Thank you, Chairman, and can I thank the witnesses for their evidence. A number of questions. First of all, to Professor Casey, she made the point in her presentation that in relation to the UK statistics that 4 women had died by suicide before the birth of the baby. Can I ask you the question, do you think that that rate would have been higher if abortion hadn't been available in the UK? If I could turn to Professor O'Kane in relation to her evidence, and you've made the presentation here saying that suicidal ideation seems to be far higher frequency than the other speakers that have given evidence here, and that a lot of it tends to be presented at GP surgeries. Now, it is disappointing that we don't have evidence from the GPs in relation to it, but in light of that, in relation to the level of the frequency, do you then believe that if a decision has to be made by a perinatal psychiatrist, that there's going to be a far greater number of cases being presented to them than is currently the case? And if I could ask Dr. McCarthy, the expert medical group has made a recommendation in relation to a physical illness that you're going to have 2 medical professionals have to sign off on a termination. It recommends in relation to a mental illness that you would have 1 physical specialist signing off and 1 mental specialist signing off on that. Now, do you agree with that? Do you believe that it should be 2 psychiatrists that would sign off on it? Should there be 2 perinatal psychiatrists that should sign off on it? And just very finally then, Professor O'Kane, you made the point that you don't believe that there should be 2 psychiatrists that should sign off on it. But I would ask you to comment. We've 5 eminent professionals here, and there's 3 very different stories coming from the 5 professionals here before us. And do you not believe, in light of the variation across the profession, that having 1 psychiatrist signing off could maybe not lead to a consistent decision across the country?
Thank you. And finally in this session, Senator Crone.
Gurmalgut, I'm sorry, please don't assume any disrespect when I'm sitting down. I'm too tall for the microphone. I have a few questions for Professor Casey. Professor Casey, I believe that your evidence that suicide in pregnancy is rare is extremely credible, and it is entirely within your professional competence. I believe that your statement that there is a lack of evidence that abortion ever will end a suicidal tendency in a pregnant woman and will never save her life is plausible, but it is a little bit speculative. My question for you is, do you believe that this set of circumstances has never happened? Do you believe that this set of circumstances could never happen? If you believe that it could happen even once, wouldn't you want the legislation in place as a doctor to make sure that women were protected against that eventuality occurring, being cognizant of the fact that if the suicide occurs, there will, according to the two-patient theory, be two deaths? I finally, and I'm sorry if I'm being a bit provocative when I say this, Professor, but your prepared statement, I'm sorry I was not here for the entire written statement, but your prepared statement does allude to the argument that there may be a floodgate phenomenon, that there may be an abuse of a suicidal ideation clause in any abortion legislation. Now, I would, with great respect, say that this is entirely without your professional competence. This is not something you should be discussing. This is not something which is within your remit as a psychiatrist. It may be within the remit of those who look at sociological trends or at lawyers or forensic analysts of various kinds. It is not something that a psychiatrist should be testifying about. And I would state that that level of testimony would more appropriately be heard, perhaps, in our meetings on Thursday. And I do note that you are an affiliate of an organization which I believe also has a non-professional, entirely legitimate, but non-professional argument to advance in this argument.
Professor Casey's here in her own professional guise today. To be fair to Professor Casey, now, it would be unfair, Deputy, or Senator Crone. Professor Casey is here as an eminent psychiatrist herself, so that would be unfair to
and I respect her opinions on matters related to psychiatry, but she has strayed outside that area of competence to comment on a broader social policy, which is more relevant to her other affiliation.
Thank you. Thank you. Okay, if Dr. McCarthy, and I'm conscious before the speakers want to speak as well, so if we can keep our answers to brevity, please.
Okay, and I'll try and bring the answers together as much as I can. I think actually there's probably more agreement between us than has been accepted there. There's actually been a lot of very common ground. There are some differences, but there's a lot of common ground, and I just wanted to state that. The question about numbers and how many numbers of psychiatrists, I think we do need to understand the processes here. People going to GPs, well-women clinics, positive options, then maybe going to a psychiatrist. Should there be a second psychiatrist? I personally think that certainly because it's going to be I think it's going to be rare, and I think because it's initially certainly going to be such a difficult area, I think for a psychiatrist not to get a second opinion would be foolish. I'm afraid to have to slightly disagree with Veronica there. I think there should be a second psychiatrist. Of course, we don't carry out determinations. An obstetrician would have to do that. So the obstetrician would have to see the patient, of course, as well. But I doubt there's too many obstetricians who would say they have a competence in assessing suicide. So they want to see the patient, of course, but the actual saying this person is suicidal and fulfill the criteria, that would have to be psychiatrists. And I do think there should be two in that regard. With regards to the CMAC report and the earlier referral, let me just state I am the CMAC assessor in psychiatry in Ireland, and I do see these what's now called the confidential maternal death inquiry, and we do certainly see the delay in referral to specialist treatment. But that's not just in pregnancy, let's be honest. There's a delay in referral across every specialty, not just in psychiatry, and it certainly can be an issue here. Could we treat somebody early enough? I mean, again, the vast majority of women who are depressed in pregnancy are not going to be coming into me saying, I'm suicidal, and if I get a termination, I will be better. The vast majority are going to say, I'm suicidal, who are that severely depressed, are saying, I'm suicidal, I'm depressed, I'm miserable, I feel awful, I feel dreadful, all the typical symptoms of depression, and they will want to be admitted to hospital, will want to be treated. It's not going to be a question of keeping them well enough. It's going to be a tiny percentage. So there would certainly be, I'm trying to imagine what patient might fulfill the criteria you're worried about. Maybe somebody who's come into the hospital, like maybe women I've seen who've maybe taken a very serious overdose, almost killed themselves in pregnancy, are too unwell to go home. Yes, she might be saying, I really want a termination now, but maybe at this particular moment she doesn't have the competence because she's so depressed, maybe even delusional. Well, of course, in a circumstance like that, we will keep her in hospital and treat her, and very often, she will get better, and I will certainly have seen women afterwards who will have been delighted that the depression was treated, and afterwards they wanted the baby. Equally, we do see women, and here I certainly support Professor King, not every woman who is suicidal in pregnancy saying, I don't want that baby, is mentally ill. I mean, that's a ridiculous suggestion. Many will be seriously depressed, and that depression may make them feel they want to reject the pregnancy. But some are just distressed, depressed, hopeless, and feel because of socioeconomic factors or lots of other factors, or personal factors, or relational factors, or they're being beaten, the hell has been beaten out of them by their partner because men are more likely to abuse women in pregnancy and beat them up than at any other time in women's lives. And they want out in that situation. She's not mentally ill. And that's what we have to recognise, and these are real. And at the moment, she's likely to go to England to have a termination of pregnancy, or to Northern Ireland. If that's not available there, I would be worried about a lot of these women. That's the truth of it. As long as it's there, it's going to be a tiny group, and that's the reality. And that's what we have to face as a country. What do we want to do about that, or do we want to leave it as an export? Waiting times to see a perinatal psychiatrist, well, obviously, I'd say there are only 3, and we're all in Dublin. Most women, however, as I say, most women who are depressed are going to want to see their psychiatrist locally. It may not be a perinatal specialist. The specialism that we have is going to rarely address to this particular issue. Our specialism is that women who maybe previously have bipolar illness or schizophrenia or on particular medications, maybe had particular obstetric experiences before. They want to see someone who understands the obstetric issues of the interrelationship between that and pregnancy and psychiatry. They don't necessarily want to come in this circumstance. This is a very small group of people, and if this legislation does come in, if there are guidelines, I imagine there will be a pressure on us to see them and see them quickly. I don't personally look forward to that. I'll be looking for more resources as a result, but that may happen. I think that's just all as best answers I can give.
Thank you. Professor Casey.
Thank you. Now, a workable proposal, I'm probably not the person to answer that, since I don't believe that we should be legislating for suicide risk under the proposed legislation. I think it's going to be bad law because it's not based on any evidence relating to suicide and pregnancy that we know of. The specialist referrals that Mr. Burke refers to, yes, I mean, the British CMACE, the British equivalent of CMAC that you've referred to, commented that 69% of women dying by suicide had suboptimal care. And some of that wasn't because of delay in referral. It was actually after referral that they were not treated properly. But yes, anything that promotes earlier referral and vigorous treatment is absolutely essential as a way of combating maternal suicide. Mr. McSharry raised the question of how rapidly suicidal patients can be referred. Well, even though there are only 3 perinatal psychiatrists in Ireland, there are psychiatrists all over the country, and people can be referred to the accident and emergency departments because all of the psychiatric services in Ireland have psychiatrists on call every day, 24 hours a day. They have a junior doctor and a consultant, and they can be referred there. So there isn't a problem about emergency referral for any person, a pregnant woman or anybody else. The unpredictability, will that increase the potential number who are being referred for abortion who actually turn out not to be suicidal? And that's absolutely right. If you predicted that 100 women were suicidal and therefore in need of abortion, and in fact only 3 really would die by suicide, then yes, there is going to be an over-referral, and that's one of the difficulties that we would, I think, err on the side of caution. And I know when I see people who come into hospital or into the Mater Hospital A&E who are suicidal, be they man or woman, if I'm not sure whether they're suicidal or not, I will admit them to hospital. If the choice is between abortion or not abortion, I think many psychiatrists would possibly, some psychiatrists probably may err on the side of caution rather than run the risk of the woman taking her life. So that's a concern. The UK statistics for women died in pregnancy, would it be higher if abortion were not available? I would doubt it, because abortion is available there, and if it was thought that abortion would have helped these women, they would have had it. As I've said, this report, the CMACE report, emphasised that there were deaths by suicide after pregnancy as well, after delivery, and they emphasised that all of these were due to mental illnesses that hadn't been adequately and vigorously treated. Unfortunately, there were 4. Some didn't fall into that category, but suicide does occur, sadly, even with the best treatment in the world, because it's unpredictable. Professor Crown, suicide is rare. Yes, you accept that. You seem to be, you speculate that I'm incorrect, saying that abortion never ends a suicidal tendency. Well, you know, we have to practice evidence-based medicine. And I don't know if you've read the Royal College's report on, and maybe you didn't hear that part of my evidence, where they carried out a systematic review, and they concluded that when you control for all the relevant confounders, a woman with an unwanted pregnancy, whether she had abortion or whether she gave birth, made no difference to her mental health. There was also a study from Finland that I didn't get a chance to mention that related suicide in women who had abortions, had miscarriages, or had given birth. And they found that among those who had abortion, the suicide rate was 3 times the national average. After giving birth, it was half the national average. So there is data out there to support the proposition that there is no evidence that abortion helps women's mental health. The floodgates phenomenon, I've mentioned, yes, that I believe there will be a gradual attempt to extend the law. We've already heard it suggested today that it should include mental health as well as suicidality. That process has begun. So I think there will be widespread abortion in a short period.
Thank you. And Professor O'Keefe, I've got 4 more speakers who want to speak as well.
Thanks very much. I'll be brief. I mean, I think one of the reasons there seems to be a bit of disagreement amongst the expert witnesses here is because we're debating slightly different things. Professor Casey is talking about not bringing forward legislation, and the rest of us are talking about what that possible legislation and regulation might be. And I certainly came here today to talk about what the legislation and regulations would be, because that's the remit. That is actually the title of what we've been given today. So I think some of that disagreement may be related to that, but amongst the body of psychiatry, there's absolute consensus that we're able to assess risk. The issue in relation to 4 deaths being predicted by 100 is we're saving 97. We're saving 97 people. Like 100 people don't die. All of medicine, not just psychiatry, is about risk assessment and risk management, everything. And obviously, if somebody is at risk of suicide, we will do everything we can to prevent that, because it is in our interest to save a person's life and to bring them back to as full a health as they can enjoy. That is why we become doctors. That's what we do. In relation to the last point, Patricia said psychiatrists run the risk of erring on the side of caution. I'd just really like to point out that it's not psychiatrists who are running the risk. We are just conduits for this proposed legislation if it happens. It is the woman who runs the risk. It is the woman who, after she gets the information or the agreement or consensus from whatever experts are requested in the process that might be legislated for, after that the woman decides, and the expert reports emphasises this, the woman will decide after that whether or not she wants to continue to have a termination of pregnancy. So it's not psychiatrists who are determining this, it's actually the woman who is involved.
Thank you. Senator Van Turnhout.
Thank you very much, and I'm very conscious of time, so I won't repeat previous questions, and thank you all for your presentations. For me, it's clear that we're operating within the parameters of the proposed legislation and supporting regulations, and in that light, my question is, can you elaborate for me what role you think your profession, psychiatrists, should have, whether it should be advisory, sign-off, what level of role they should play, and do we need to differentiate particular situations? And I was particularly struck, Dr. McCarthy, under point number 22 in your presentation, and Dr. O'Keefe, you talked about childhood abuse, but particularly children and vulnerable adults, if I put them into that category. Is that something that we need to differentiate within supporting regulations? And I would very much welcome an input on that area. Yeah, I'll leave it at that.
Deputy Fitzpatrick. Thank you, Senator. Deputy Fitzpatrick.
Thanks very much. So just 3 questions to ask here. The first question is, do women who have abortions, do they increase the risk of mental health? Like, i.e. like depression, panic attacks, panic disorders, or substance abuse disorder? The second question I'd like to ask is, women who have abortions, are they more likely to commit suicide? And the last question I want to ask is, does motherhood protect against suicide? That's 3 questions. Thank you.
Thank you, Deputy. Deputy Regina Doherty.
Thank you, Catherine. Thank you all for coming in today. Can I just ask a question in light of the statements that all 3 of you have made, except until we got to Professor O'Kane, it was kind of like the elephant. Keane, sorry, apologies. It's like the elephant in the room. Suicide in pregnancy is very rare. That's not to say that it doesn't exist, except what we haven't addressed is all of those people that you're talking about. And I think it would be ironic that we're all here today arising from the X case. We haven't talked about a scenario like the X case of a 14-year-old girl who didn't have an obstetrician, whose parents or mother saw fit because her child expressed severe, thoughts of suicide to bring her child to the UK to avert her losing her own daughter's life. In your opinion, to not lose sight of all of those people, whether they be 14, 24 or whatever age, what option in the expert case is the best scenario to address those people who don't have perinatal psychiatrists, who don't even have a psychiatrist, and in a lot of cases don't even have an obstetrician?
Deputy. And finally, Deputy Mary Mitchell-O'Connor.
Thank you very much. With regard to the floodgates phenomenon, I'm hearing much criticism about the psychiatry profession, and what's being said is that stop shops will be set up where 2 psychiatrists will come into a town, will sign all these documents, and then the floodgates will be open. Can I ask you, the 3 of you, as professional psychiatrists, to comment on that criticism that's being made? Thank you.
Thank you. And we've 10 minutes in this slot remaining, so I'll start with Professor O'Kane this time.
Okay, thanks very much. In relation to the floodgates phenomenon, in fact, I think we've addressed this already, and I don't really want to repeat it, but basically my view is whatever happens in Ireland needs to be determined by reality. At the moment, what's happening is that Irish women who are suicidal are going over to the UK and they're availing of the services there, of private health services there. That is effectively what's happening in Ireland at the moment. Whether that's going to change because of this the introduction of this legislation, I don't know. Professionals will operate within the limits of the legislation. If the limits of the legislation say that it's only in extreme and rare circumstances where the actual risk, substantial risk to the life of the mother, can only be averted by a termination, well, that's the law that we work within. But obviously there is a need there. The need is there. Women are going to the UK, they're having terminations there, and the majority of them are having those terminations for mental health reasons. And that is not to forget about the very tragic group of women who have hugely wanted pregnancies and who shamefully are going to the UK to have terminations. We're not including that group of women. So it's not obviously everybody who goes there who has an unwanted pregnancy. In relation to the point that the lady in the pink jacket made, I don't know your name, I'm sorry. I think your point is extremely valid, and I do think we've sort of lost sight of this. In a sense, what has promoted the whole debate has been the X case. It has been something that could happen to any 14-year-old child, any teenager in this country. At the moment, these people are travelling to the UK, and I don't think there's a will in the Irish people to take away the choice that we have as citizens to travel to the UK. We have had we voted on that as a country, and we've said we want people to have that right. So effectively, that is part of the services that Irish women are using.
Right, thank you.
Thank you. First gentleman, Mr. Connors, you spoke about the role of psychiatrists within the parameters of proposed legislation. The issue for me about psychiatry... My microphone.
No, it's okay. It's not
Can we just...
There we are. Thank you. The role of psychiatrists within the proposed legislation. Psychiatrists are people who treat mental illness. So if somebody is depressed, anxious, has schizophrenia, whatever, we offer them treatments. We've already heard from, certainly Veronica, not everybody who is suicidal has a mental illness. They're suicidal simply because they don't want to be pregnant. At least that was my understanding of what you said, Veronica. And if I'm reading and understanding you correctly, I wonder what role do psychiatrists have if somebody doesn't have a mental illness? So if somebody isn't mentally ill, what are we doing? So I think that's a very important issue. Are psychiatrists being used in this simply to get the government off the hook, to find an easy way out for some of these cases? I don't know, but it's something I think that you need to reflect on. The second, Deputy Fitzpatrick, the increased, yes, does abortion increase the risk of mental illness? The study, there's debate about that within psychiatry. And there was a big study from the Royal College of Psychiatrists, the systematic review, that showed there was no increase, and that generally, and that whether a woman had an abortion or gave birth to an unwanted pregnancy, the outcome was the same. But for a subgroup of women, there was an increased risk. Those with prior mental health problems, those who were being coerced, adolescents, there were a group of people that were at increased risk. There's another psychiatrist called Ferguson, who is actually a pro-choice person, and he has done a lot of research in this, and he believes that abortion does increase overall the risk of mental illness post-abortion by about 30%. So there is disagreement on it, but everybody agrees that certain groups are vulnerable to an increased risk of mental illness after abortion, and particularly people with prior mental illness. Does abortion increase suicide? There is certainly an association between higher suicide rates and having had an abortion, as I've said, from a series of studies in Finland that one can refer to. And does motherhood reduce the risk of suicide? Yes, there is a body of evidence showing that parenthood and motherhood is protective against suicide. Ms. Doherty asked about the X case and that we'd lost sight of her, and I would agree. Unfortunately, though, when Ms. X presented, she didn't have a psychiatrist. She wasn't receiving any treatment. And in fact, in the judgment, the judges mentioned the fact that no treatment suggestions were offered. So if she had had input at a psychological level, who knows how she might have felt. And of course we do know about Miss C, because Miss C was the other young woman in very similar circumstances, the same age, was raped, was taken to England for an abortion because she was so acutely suicidal. And then she came back and went public and said she wasn't fully informed about what was happening, but more significantly, she actually was suicidal and was in hospital for a considerable period of time. And finally, the floodgates phenomenon and the criticism. I don't think that psychiatrists are going to be responsible for the floodgates, because I think that psychiatrists are people of integrity and will act within the law and will act in good faith. But I think what's going to happen is that because there will be a lot of people coming forward for these assessments, and indeed our colleague Dr. Siobhan Barry commented on that recently, she believes there's going to be a huge pressure on the services there, and the assessments won't be able to happen quickly enough. I think there will be an attempt to dismantle the current restrictions and extend them.
Thank you. Dr. McCarthy, 3 minutes if you can.
Okay, I'll try and be as quick as I can. Number one, Deputy Mitchell O'Connor's question about people setting up in the town. Firstly, the recommendation would clearly be that anyone doing this should be on the specialist register and approved by the College of Psychiatrists of Ireland and by the Medical Council to do this sort of work. The idea that all of us who are working so hard and overworked will be going around in caravans, as long as it's not a private external service doing this, I would have no concerns about that. Deputy O'Doherty, absolutely. Children are a key issue in all of this, and that's where my colleague is here before. And there are really detailed issues that you would need our support on, our advice on, and our help on in this regard. With regards to legislation and guidelines, for example, children in care, there are particular circumstances. For example, that a 17-year-old, any child under the age of 17, to have a psychiatric assessment, their parents must consent to that. But actually, they could have a termination of medical treatment without consent. So there's lots of issues like that, and with regards to the Mental Treatment Act, that really do need to be addressed and thought through and worked through, and we'd be very happy to work with you on that. Does abortion, is that bad for women's mental health? I mean, Professor Casey has mentioned this a few times. Absolutely unequivocally, every one of us working in this field will see, this is the real area of saying the importance of appropriate assessment and not seeing people as statistics but as individuals. Every one of us working in the perinatal service will have seen women who've had terminations of pregnancy, and the subsequent pregnancy will feel profoundly guilty about that, and it'll be a negative effect for them. We'll also see many women who it has not been a negative effect for, who's been a positive thing, where they always say, I'm glad I did that. How did that affect you? Oh, that was right for me at the time. So we really, really, really have to look at the individual in this circumstance and not be generalizing. overall neutral in terms of statistics, but for individuals, hugely important. And hugely important they are assessed properly at that time. And if they're mentally ill, and if they don't have the capacity, we treat them, we help them. If not, we don't label them as mental illness. Then Professor Casey mentioned, if they're not mentally ill, what are we doing with them? Well, personally, I trained as a psychiatrist. I've also trained as a psychoanalytic psychotherapist. I got a master's in that area. So I don't just treat mental illness. I treat people with psychological distress. That's not necessarily illness, but it overlaps, or it's part of the picture. And any of us in psychiatry shouldn't just be tablet prescribers. We should be providing psychotherapy, support counselling, and many other things as well. The only other particular issue, then, are we supposed to be advisory? Are we supposed to be signing off? Clearly, our role is advisory in this regard. We will be the key advisors on the mental health, on the suicidality. That's our role, I think.
Thank you. Okay. That concludes this session in terms of the members of the committee. It's now open to non-members of the committee for 20 minutes, and there are 8 members who've indicated for 20 minutes. So I will take the first 3 in the order of indication: Deputies Flanagan, O'Riordan and Duck. And you got 2 minutes, Deputy.
Thanks, Cathaoirleach. Just to ask Professor O'Kane, your submission suggests that suicide can only be addressed by termination of a pregnancy, yet your perinatal colleagues say they've never said or seen such a case. Just to ask you what the psychiatric textbooks actually say on that matter, and have you any scientific basis as well for your belief that abortion will help that woman in that instance? You previously stated as well that if a woman told me that she were suicidal, I would believe her, yes. So just to ask the question of any investigation taking place in these type of cases. Can I ask the panel, how often have you had to treat a pregnant woman who stated she was suicidal? How accurately can a threat of suicide be assessed as well, in all likelihood that it will be acted upon? And to ask as well, would you agree with Dr. Justin Brophy that suicidality can easily be feigned as well? Do you think that there should be any restrictions, time limits on providing abortion where suicide is threatened or is at risk? Would you agree with abortion after 30 weeks, for instance, where suicide is threatened? If not, what would the options be? And finally, just to ask, do you believe that there are 2 patients in a pregnancy? Do you believe that the unborn child deserves a duty of care?
Thank you, Deputy. Deputy Éanna Riordan.
Thanks, Cathaoirleach, and thanks to the expert witnesses for being here. I just want to make the point that, discussing whether or not suicide should be part of this legislation is completely futile, because it has to be part of this legislation, or else the X-case legislation that we are bringing before the House and have to vote on is not in keeping with the Supreme Court judgment, and it's not in keeping with 2 referenda which are passed by the people, and it's not in keeping with the X-case, which was all based around a suicidal 14-year-old. So I wish we could stay away from the debate as to whether or not suicide ideation has to be part of this legislation. It has to be, or else it's not in keeping with the Supreme Court judgment. So on that basis, I would ask Professor Casey, because she has said legislation has to be based on good medicine and fact. The fact is that legislators have to deal with the constitutional provisions laid down by the Supreme Court and also by the Irish people. So given the fact that suicide will be part of this legislation, how best does she feel, seeing as she hasn't answered this question yet, how best does she feel that can be dealt with by people practicing in her field?
Deputy Durkin.
Mr. Chairman, could I just hark back to the issue of the patient, the women. To what extent, in the absence of legislation, can women who are pregnant or girls who are pregnant, by whatever circumstances, be reassured that their particular case and circumstances would be treated equally and fairly in the absence of legislation? And in the event of legislation taking place, would there not be an obligation on all practitioners at all levels to ensure that each case was treated in accordance with the legislation? Can I further ask in relation to the floodgates reference, and reference has been made to UK stats, what about the stats from Northern Ireland, and to what extent are those stats available in order to further pursue that particular act? The number of women who have died during pregnancy, in whatever circumstances, over the last 25 or 30 years, to what extent, I seem to get information from Professor Casey's reference that the number was very small. So I would like some clarification on that, because I would, as other members of the House would, have knowledge of some of those situations as well. And the last point, Chairman, given the necessity to reassure women or girls who are pregnant, how best does the panel suggest that that reassurance might be given, particularly in a situation where there might have to be a debate, a discussion, amongst a number of people, practitioners, legal practitioners or otherwise, as to what the proper procedure was in particular circumstances? What is the right way to go about that? And can our panel give us an opinion that would reassure women in those circumstances?
Thank you. And very briefly, Senator Brennan.
Just to give a short story of my own that I discovered about 10 or 11 years ago. I met a young man whom I had been told 10 minutes beforehand or 15 minutes beforehand that he was going to commit suicide. And I said to myself, what am I going to do about this? How can I ensure that it doesn't happen? But I have been told. So into my car, banged as fast as I could. The young man was in his grandmother's house. I think I may have told that to some of my colleagues in the Senate here. So I went into the kitchen, and the young man whom I was told was going to commit suicide that night, and he's standing with his back to the fire, and he's in great form, and he's talking to everybody, and he doesn't ask me why I'm here, but I'm there because I'm after being told by the previous person I spoke to that he was going to commit suicide. I looked at him, this is ridiculous. No way is it going to happen. That's why I'm leading to our panel here this evening. What are the... I didn't have a clue. I was an ordinary guy. I played football. This guy played football. I probably got talking to him about the contribution he could make to his team or blah, 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 and I wanted to see him back playing football again. And it happened. He's married. He has 3 children. I don't know whether... I don't claim any credit for it. But what I would like to ask the panel is, what are the main issues that you have when a woman comes to you and says, I'm suicidal, I'm mentally ill, I want an abortion, to establish that, in fact, this is the case? Now, I have great confidence in the women of this country, of the mothers-to-be, of mothers that already have had children. And the question of the issue of rape, when it happens, now I'd have to say that I am aware of it happening in marriages. What is the panel's view on an issue of rape in marriages?
Professor Casey, you want to start? And we have 4 other speakers as well following the panel, so if we can again keep our answers. Thank you.
Thank you. In fact, I didn't hear all the questions, unfortunately, because I couldn't hear the gentleman down there, and I had some difficulties with the gentleman there. Somebody, so I'll answer the ones that I have heard. I heard the gentleman up there ask about 2 patients in. Do I believe there are 2 patients in pregnancy? Absolutely. I think, you know, when the practical thing of giving medication, you think if you are prescribing medication to a woman who's pregnant, you think, will this harm the baby? Will this harm the woman? So yes, of course, we regard ourselves as having 2 patients. You've mentioned. Yes, no, I'm sorry, that was all you mentioned Dr. Brophy, but I didn't pick up what you said about Dr. Brophy. I don't know if... Okay, all right. Mr. O'Riordan is expressing, I suppose, irritation with me that I haven't... that I'm not supporting legislation for Exon, that, you know, I've come here to give my expert opinion to this group. I've done it in good faith, and I've done it based on my many years of clinical experience as a professor of psychiatry and as a clinical psychiatrist in the Mater Hospital, and based on research. And that's what I'm going to do. And if that isn't what you had in mind, I apologise to you, but I have done it, I hope, with integrity and to the best of my ability. How can women...
can I just the point? The
Very,
point
very,
is,
very brief now.
yeah, the point is, I'm not questioning anybody's integrity here, but the suggestion, the point is that we have to legislate for suicide. That's my point. It's not whether people believe it should be or should not be.
Thank you.
And,
Sorry. We're not going to have a slagging match, Senator Walsh. We're going to have a very calm, dignified debate we had all day. Thank you.
in that scenario, because as part of the X case judgment which we were debating here is X case legislation, in that eventuality,
Major point, Deputy.
how does the Professor feel that that should be done?
Professor Casey has made her comment in good faith as well. Thank you.
How can women who are pregnant be, in the absence of legislation, be reassured? Well,